Hey everyone, today we're going to be talking about some gravity complications when it comes to our patients. And something that we have to really understand is the trauma process. And when we're talking about the trauma process, we're talking about, so we have an initiation of injury. And that can be either from fall, which is probably the most common kinds of head traumas we see is falls, but we've also seen assaults. So like I took care of a patient that had gotten beaten up with a 2x4, and that is definitely going to cause some issues when it comes to, thinking clearly and survival. So what we want to talk about though is mainly falls because they are what you guys are going to see a lot of. It's what we see a lot of. Thinking about our population that is more at risk for falls, who do you think that would be? Think about our elders. Think about how often we're worried about them being a fall risk, and because of either chronic illnesses or other issues like medications they might be on or weakness that they might have. So they unfortunately become huge fall risk patients. And then think about what other kinds of medications they're on. When we talk about our anticoagulants, okay? When we're talking about our anticoags, the Lovenox and the heparin and the Coumadin and the Plavix and all these kinds of things that these patients are taking, it becomes a really big concern. Why? Because when these patients fall, there becomes a problem with bleeding in the brain. And if we start having bleeding in the brain, you can't exactly put pressure on it like you would, if you had bleeding on your arm. So what happens is that bleeding, if they're on these anticoagulants, just keeps going. Well, that blood is going to have problems because there is only so much space inside the brain. It is an encapsulated area and becomes a very large problem for our patients. The one benefit our elderly has is their brains are slightly atrophied just because of old age and if you don't use it, you lose it kind of mentality. And just like, we lose our arm muscles after we age, we lose our six pack, we lose, just all that strength. Our brain is the same thing, and it will slowly atrophy, which gives it a little bit more space. But that also means it also gives it more space to move around. So when they fall, they have a huge issue. Now, there's a couple different kinds of problems when it comes to head falls. So you have the initial trauma that happens right here. So say this person face planted on the sink and they have all that trauma here. Well, if the brain moves forward and then it moves backwards, you now have trauma back here on the backside of the brain. That's called a coup counter coup. That's that movement of the brain inside the skull. The brain is not fixed, it's kind of floating in there. And so that's something that we have to pay attention to, is if they had that kind of injury. Think about other patients that we have or other things that we've seen where injury becomes an issue as well. Think about all the things with the football and sports. Concussions become a huge issue. Concussion injury is what we call a diffuse axonal injury, where there is all sorts of micro damage to the brain from the brain having a quick shearing type of movement. It's actually almost easier to take care of a patient who has a significant injury to one spot in their brain, because we can kind of go in and fix that. Diffuse axonal injury, or DAI, it becomes really hard to take care of. And it's on a spectrum, like we talked about before with lots of things. Concussions are on a spectrum. You can have a really mild or low concussion where, it's a kid where they've had they've got their bell rung on the football field, and we now have a bigger problem, just keeping them at home and all that kind of stuff, versus a patient who has a pretty significant concussion is what we're seeing, or a stacked concussion where they've had several concussions over time. We're starting to see a lot of that stuff in football, right? Like they are not responsive, or they can't hold things together, they can't finish a sentence. And so this is becoming then a big issue, and definitely a life-altering issue. This guy here is not necessarily a life-altering issue. It's just definitely going to be something we need to take care of. Think about the signs and symptoms of concussions: nausea and vomiting, headache. They usually have some sort of amnesia when it comes to the concussion event. So a lot of times they don't remember the hit, or they don't remember how they got back to the bench or whatever. So we have some amnesia. We have light sensitivity. We see that pretty often with concussions. And then we see that it takes a pretty significant amount of time to resolve. For some reason, the brain just does not like to heal fast. And so it takes time to heal. Think about each one of these cells is having swelling happening around it. So that's why it's so hard to take care of these patients, because they're having the swelling that's happening around each area of the micro damage and on the neuron and the shearing force that happened. So we have to really pay attention to that that's going on. So how are we going to help them? Well, our goals for any head injury are to decrease swelling, and we want to decrease stimuli to the brain. Why do we want to do these things? Well, we talked about decreased swelling. If we do not decrease the swelling that's happening in this enclosed space, what happens is that brain will eventually herniate down, or have what they call a brainstem herniation or a brain herniation. Once that happens, you are now an organ donor. There's no fixing, there's no going back on that one. So we have to really pay attention to that. With our patients that are in our facilities and have this, or if we're in a clinic and we're working with kids with concussions, that decreased stimuli becomes really, really important. I always talk about our parents love to pet their kids. You know, they're caressing their arm and they're telling them they're going to be okay, and they rub their eyebrow and all that kind of stuff. Every time you touch and move across the skin, you now are stimulating all those nerves, which, think about it, all this area now is getting stimulated with where you've touched. And we do not want that. We want to decrease stimuli. So we don't want people to pet their loved ones. Don't pet them, just hold a hand to decrease the stimuli. The other thing that we're going to want to do is maybe we're going to decrease the light. You know, we're going to decrease light. We're going to decrease electronic time, which, you know, everybody gets sad about, but you'll be surprised. They really can't handle the electronic time. They just get dizzy, or they get lightheaded, or they start having a headache or not feeling well. And that's because their brain has been overstimulated and it needs to rest. Think about it. This is, guys, is the same healing process we've talked about over and over and over again. We want to decrease swelling, and we want to decrease the use of that area. So, like, think about it. When you've sprained an ankle, you rest, ice, elevation, right? We want to do that same kind of stuff to the brain. We don't really want the compression on the brain, however, because that's just, unfortunately, because it's in the skull, that happens. So we want to really decrease those kinds of things. When it comes to swelling, we need to think about, what do we do for swelling? Well, when I have a sprained ankle, I ice it. Well, it's hard to ice the brain, right? If you have somebody that's really, really bad and is probably going to get shipped to the ICU, so maybe you're working in rural Nebraska and you are going to life flight this person, what can you do while you still have them? One of the things you can do is you can ice them or cool them. You can't really put ice like directly on the skull, because just like having a cast, you don't necessarily want to ice a cast, you're trying to ice above it so that the blood flow carries the cold. So same thing with the brain. We're going to put ice probably around like their neck area. We might put, you know, kind of in the back of the neck. We might put ice in the groin and in the armpits to try and help get that swelling under control. How are we going to know if somebody has a brain injury? There's some really basic ways, right? Besides the nausea, vomiting, the headache, and the amnesia from like kind of that concussion area, and you know, this increases all the way up to different more significant symptoms. But that change of level of consciousness, this is going to be your first sign that you've got some sort of head injury, whether it be confusion, whether it be not responsive. These are going to be our things that tell us that something's wrong. I know the TV shows like to show pupil changes, all right? And pupil change is, or that they're unequal, right? That's something the TV shows like to show us. They have blown pupils, right? It's dramatic. It's actually pretty a late sign. So if you are working with pupils, you have missed so many other signs that are happening. And so we need to make sure that we're paying attention to the signs that are there. Level of consciousness is going to be one of our first signs. When do we know we're in trouble? For signs and symptoms, this is going to be when we see things like increased blood pressure, decreased heart rate, and irregular breathing. So I know you guys always think I'm nuts when I'm asking you, is their what's their rhythm of their breathing? It's really important because when you look at a pattern, the rhythm of their breathing, if it is irregular, that means that neurocenter is starting to be disrupted and can cause a lot of problems. These three things are called the Cushing's Triad. It's really important that we know these. Hopefully you never ever see them. What they mean is that now we have such an increase of intracranial pressure that we're going to have some problems. Now, like the others, other types of concussion or DAI or head trauma, we want to decrease still. Our goals are the same, right? We want to decrease the swelling. Our goals don't change. Our goals don't change just because the problem becomes bigger. It just means there's more we have to do. So our goal is still to decrease swelling. Well, how do we do that with an increased ICP? I am going to make sure that they are aligned. Meaning and I totally spelled that wrong, but meaning we want to make sure that that spinal cord is totally aligned so that fluid, CSF fluid can drain down the spinal cord as it needs to. We want to make sure that their head is elevated. So while we talked about in shock, we want them to lay down, right? Because we want to perfuse. So you have to think again about the science behind it. Their head is swollen. Use gravity as your friend. Get them sitting up. Get them upright more. If we have them laying down, you've now increased the swelling to the brain. It's easier for it to swell. We want to cool them. Get them cool. We want to decrease the stimuli. So if you are on a scene and a car wreck and you've got someone who's freaking out next to you, that is going to cause you a lot of problems with decreasing the stimuli. So we want to decrease stimuli. Other things to decrease the swelling, we do not give hypotonic solutions. This is bad. Why would this be bad? Think about what happens when we give a hypotonic solution. Where does the water go? It goes into the cell, making the cells fatter and bigger. So think about the hypotonic solution that we could easily give a patient. We could easily give them water. Do we want to give them water? No. We want to give them something that is either isotonic or hypertonic. So we want to make sure we're giving them Gatorade, maybe with an extra scoop in it, something that's giving a little bit of electrolyte, something that's creating the solution to be different. If we give an hypotonic solution, we actually increase the risk of swelling. So that's something to pay attention to as you're working with your patients that have head injuries. And most of the time, our head injuries are pretty simple. They are, more this stuff, they're more just a concussion. Oftentimes, that's what we're seeing is concussions. And that's why we're seeing so much research and push and helmet safety and, like my kids on a hockey team, and we see a ton of the coaches learning this. But what we have to think about is our elder population, how that changes it. Remember, their brains become smaller, so they have more wiggle room to happen. They're on a lot of anticoagulants for their AFib and all their other stroke issues. So that's something we have to make sure we're really assessing. Now, if a patient is bleeding, that is the least of our worries. I know we always want to jump to the blood first, but I will tell you airway, breathing, circulation is always going to be before that blood that's on the floor. That doesn't mean that we don't change our care because of the blood. It does mean that it's not necessarily a priority. So Think about that as you're working with these patients. Think about their safety and think about how we have to work with them so that that we can make them heal and we can give them the best chances of surviving this type of injury as possible.